Good afternoon, and please lend me your ears. Thank you, Professor Gupta, for this wonderful platform to voice patients' concern and some of the clinicians' concern as well. Well, this is a long topic. I'm glad to hear that something is being started in our country, because the rest of the world, good research progress has been made in a very concentrated effort and consortium manner. Before I go into that, and where we stand and what is that, can I just have an idea how many of the people in the audience here had COVID? So we can see many of us had. And are you all aware of what is long COVID even today? What is happening? Well, that's what I want to say. Do you know that there are 200 symptoms ascribed to long COVID? 200 symptoms. This is as per the different authorities of the world, different regional thing. Just to name a few, well, there's a recover in the USA. The recover is resurge in COVID, recover for enhancing the recovery, research in COVID for enhancing recovery, which has been completed now from 21 to 23rd October, and now it is going on, what is on it? Recover TLC towards long COVID, to treatment of long COVID. Now, if any person who gets COVID and gets some other disease, should it be called as a long COVID? Obviously not. Are there any definitive disease diagnostic criteria, tests to tell us? Not as yet. So it is by exclusion. So to come on the same page, different parts, organizations of the world, research organizations of the world, have formulated definition, including the WHO. And that particular definition includes certain time periods, should be within 3 months, after 3 months, duration should be, some say 4 weeks, some say 8 weeks. Then they can continue even up to 1 year. Even now, people can have it. Should only those who are affected by COVID, symptomatically, means becoming a disease, or those who are positive also? Yes, positive also. They should be included. Then question comes up, why should it be related to COVID? Infections come and gone. There are many reasons for it. They have shown what we call as the persistence of the virus in human body, in reservoir at different places in the body, different areas, including brain also. Previously, it was thought it doesn't interfere with directly to invade the brain. It has been shown in autopsy. It invades not only that, and this autopsy studies is of number of the patients in the long series from 21 to 23, and that is done by NIH and NIAIDS, and especially number of the institutions together. A few hundred autopsies done, and 85 areas in different parts of the brain. Samples were taken. So those and the areas of the body where it can be involved, Professor Talwar is here, I shouldn't be saying, but that they have shown in the autopsy, and even after 283 days of the death, remnants of the viral particles in the cardiac muscles, in the heart itself. So the virus can be seen in different parts of the body, and in the living patients in the post-COVID, they could see the virus persistence in the different fluids in the body and the biopsy of the human beings. When all those things can be shown, because this is just a brief thing, otherwise I would have shown you all how the immunofluorescence technique, how the RNA particles have been shown differently. Well, not only that, I'm now coming to simple facts. Then there are certain tests are being developed now. The digital test, digital polymerase, which can pick up in whether carriers of the particular symptoms are suffering from long COVID or not. It's in the process, in the pipeline. It has not been something you go tomorrow and ask, where is that test? I would like to get it done whether I've got COVID or not. Among the 200 and all symptoms, the commonest thing which has been shown as per the recover studies is concerned, which involved over more than around 10,000 patients, right? It involved 9,000 and odd visits of the patients, 92,000 visits of the patients to the different clinics and for evaluating the symptoms. That particular showed very clearly the commonest thing was what we call as exertional induced brain fogging, exertional fatigue. And that fatigue, very commonly, every person was supposed to be because of the post-infection, because of drugs, because of hypoxia, many causes of it. But now it has also been shown, being a neurologist, I would like to show that, it has been shown that it is because of, in this study, this is a Bible journal which we call a Brain, Journal of Brain. It was in October 24 only, it was published very clearly, how the wiring of the brain gets thinned out in these patients, and when they exert mentally or otherwise, it gets exhausted. So it's the central origin as well. It has been shown, and it is supposed to be the immunological reaction to the sustained virus particles that produce these immunological changes, inflammatory changes. And that has been shown to occur in many conditions. In fact, we are talking about non-communicable diseases. People have started questioning whether it's really non-communicable diseases or they are consequence of the infectious diseases, like a rheumatic disease. Fine. So we would like to tell you something more about it, that many symptoms which are very common can be treated in a managed, may not be drug. No doubt a drug has been going on in trial, and about 40% of the people have been really benefited by that. That Paxlovid, don't ask for it everywhere. So it has already approved medication for the COVID treatment, but now it has to be given for 15 days in some of the patients who are really involved with that. That is, FDA trial has already taken place and completed also. Now, what I would like to tell you about that, what is lacking, what we are supposed to have, is a really good database of these patients. These database of these patients, as it is in the USA, they have made it what you call as, UK has a biobank, as we know it. Similarly, we have BDC in USA, Biodata Catalyst. This is data available on site, website, you can go and check it and take information from that. We have, with 22 million population, Britain can have such a data. Why can't we have such a data? We have now many things available to us. It will be available. Even the remotest area of the country can be accessed through the satellite phones also. And that can be easily converted with the Bhashini. With the Bhashini available, we have to speak, and that can be dictated onto the thing in different languages, and data can be corrected. Well, there are many things which can be spoken. So what I want to say is that you should be aware, there should be an awareness program. We should sensitize the public and the doctors specifically for that, so that we should start a movement for that, and the common forum like this would be very helpful in that. Thank you very much.